By reducing this gastric emptying, the thought is that the food that is being transported through the GI will have the opportunity to slow down or move through the GI tract slower. And this will allow those incretins, that GLP-1 and GIP, to take effect and allow for longer insulin release so that more glucose can be absorbed into your tissues and processed by your liver, but before it has the opportunity to get through the entire GI tract. So slow GI emptying relates to better or more accurate glucose absorption within the body, and it allows our insulin time, or that second wave of insulin, to act more effectively, or more appropriately is the word I've been looking for to use. This diagram kind of helps bring those three kind of concepts that we've been talking about together. So the pancreas and its release of amylin, insulin, and glucagon, our GLP-1, and how that kind of factors in there. So starting up at the top, we have food that is eaten and introduced to our stomach. So the introduction of food prompts our pancreatic beta cells to release insulin and amylin from our pancreas. The amylin is going to help suppress our appetite as well as decrease or inhibit the gastric emptying, and our insulin is going to work on our liver to promote glycogen storage. Our stomach is then going to allow our food to be moved on to the small intestine, and as our food is being moved through the GI tract, this is prompting the production of our incretins. So our main incretin that we talk about is the GLP-1. This is also slowing our gastric emptying and suppressing our appetite, and as a result is inhibiting glucagon release, which is going to occur because insulin release is increased, and we're getting an increase in our blood glucose. And so if you remember when we were talking about what prompts glucagon release is hypoglycemia, or low blood glucose. So because we are eating, we are prompting the inhibition of glucagon release and the promotion of insulin release. And as before, I did mention that GLP-1 is broken down by the DPP-4 enzyme. This enzyme degrades GLP-1 and activates it. So this enzyme is mentioned because it is a drug target, but we are able to inhibit the enzyme from degrading our GLP-1. Potentially we have more GLP-1 available to inhibit that gastric emptying, suppress our appetite, and inhibit that glucagon release, allowing the insulin a longer time to act and perform better. So improving our body's sensitivity, a word you'll hear more about later on, for our glucose. So another mechanism that helps in glucose homeostasis is the kidneys. So they play an integral role in glucose homeostasis through the mechanism of glucose reabsorption. That just means that glucose is, in order to maintain adequate glucose levels, our kidneys will work to reuptake glucose into the system if it is low, and if it is higher, it would work to excrete those. So our SGLT2, or the sodium glucose transporter, is one of the transporters that allows for glucose reabsorption. This transporter is in the proximal tubule, if you remember from renal, the nephron. I won't go into too much detail here, but this is in the proximal tubule, very close to the glomerulus. And this SGLT2 transporter that is present here allows for almost 90% of our kidney's glucose reabsorption. And so this also, I mentioned this mainly because this is also a drug target of one of our newer anti-diabetic agents that Dr. Biggert will talk about. And the drug target is to block this transporter so that glucose reabsorption does not occur. So in other words, you would be excreting much of your glucose. And you could see how that potentially would be beneficial in someone that is diabetes, as we talked about, is high blood sugar or hyperglycemia. By blocking this, we can prevent further increase in blood glucose by preventing reabsorption from the kidneys. So based on what we talked about in terms of normal glucose homeostasis and all the different peptides and hormones that interact there and how they interplay with each other, thinking about how they are excreted by the pancreas, they're excreted by the GI tract, and work on the storage of glucose or release of glucose in the liver, what mechanisms can you come up with that might lead to the development of diabetes based on the homeostasis, normal physiology that we've discussed? So take 2 minutes, think about that on your own, and then I'd like you to pair with your partner and take about 5 minutes to discuss the different mechanisms of that pathology that might relate to the development of diabetes, and then we'll share your potential ideas on what mechanisms there can result in diabetes. So I'm hoping what they'll come up with here is that, we can have, a decrease in insulin use, a decrease in insulin release. The beta cells is where we'll hopefully focus. But I do like your point, Mel, that you said that they might come up with some weird factors, and I think that's okay. If they do say, you're GLP-1 deficient, or you have too much DPP-4, because I think it can highlight that, we do understand, that they at least understand the mechanism of what GLP-1 is doing, what DPP-4 is doing. I think we just relate that that's not physiologically what happens, when we get into the actual pathophysiology of type 1 and type 2, but mechanistically you can see how that might make sense. So here, after the things that I shared, I was thinking about taking a 5-minute break. And when they come back, we start into the pathophysiology. So type 1 diabetes is mostly closely related to an autoimmune destruction of your pancreatic beta cells. The fasting hyperglycemia begins to occur around when 80 to 90% of those beta cells are destroyed. As you can imagine, as we talked about with the pathology, your beta cells are responsible for the production of the insulin and amylin. So having 80 to 90% of those beta cells destroyed is going to result in both insulin and amylin deficiency. Within 8 to 10 years of initial presentation, that beta cell loss may move to completion, so almost 100% beta cell loss. And so then your insulin deficiency is absolute, and your body is not producing any more insulin. So this happens over a course of phases. We have a long preclinical phase marked by the presence of immune markers, so the patient may not be exhibiting any symptoms. The only indication of type 1 diabetes that we would know of is if the patient had a strong family history or close relative of type 1 diabetes, and they may have been tested for the presence of those autoimmune markers. Once 80 to 90% of those beta cells are destroyed, we will start to see hyperglycemia in the patient. As you can imagine, that would be due to that lack of insulin and amylin that is no longer being produced because of the death of those beta cells. After that starts to be observed, we may start to treat them by supplementing them with insulin. And so very often you'll see initially in these patients a transient remission, or what we like to call the honeymoon phase of type 1 diabetes. It appears they start to recover with the introduction of more insulin, but eventually after the body starts to get used to the insulin that's being we move into progression of established disease. During this transient remission stage, it appears that the patient would require much less insulin than they actually will need, and after the body adjusts, that insulin requirement significantly increases, which occurs during the established disease component of the disease. Let's go into what that might look like. In our preclinical phase, we may not have any symptoms at all. There may be the beginnings of polyuria and polydipsia. Anyone ever hear of those terms before? So polyuria is just increase in frequency of urination, and polydipsia is the compensatory increase in thirst. Glucosuria is an increase in glucose within the urine, and they also see some weight loss. As they move into the 80 to 90 site beta cell destruction phase, that's when we start to see more significant symptoms, and that is most often where diagnosis will occur. So, the patient may present with increase of ketones in the blood, increase in ketones in the urine. So if you remember thinking back to the pathophysiology, when our body is not able to keep up with using our glucose stores or using our glucose by breaking it down, our body will need to go to other sources for energy. And so our amino acids that are stored in our peripheral tissues can then break down into ketones. And so when there's an increase in ketones in the blood and in the urine, that would signify that our body is not being able to use our insulin efficiently and is resulting in production of those ketones. And so that can occur, A, with not using our glucose efficiently, and B, potentially not having enough glucose, so in a hypoglycemia type state as well. We will also see significant elevations in hemoglobin A1C, which we'll talk about as one of the diagnostic and screening tools used to identify patients with diabetes. We may see recurrent respiratory and vaginal infections, and the mechanism for that would simply be that we're having an increase in blood glucose, which bacteria, yeast use glucose as energy just as we do, and so having that presence of increased glucose is going to put us at risk for recurrent infections. And we may also start to see some vision changes to that constant increase of glucose within the retina of the eye. Our honeymoon phase, or stage 3 of type 1, is after implementation of treatment. So after giving some insulin, we may see some initial decreases in insulin requirements in order to maintain euglycemia, or normal glucose levels. And this can last weeks to months, and then they move quickly into the established disease phase, where larger insulin requirements are necessary in order to keep them euglycemic. This is usually characterized as complete insulin deficiency, as their beta cells are not producing any insulin any longer. The risk of going untreated, so not treating these patients with insulin, would result in ketoacidosis and death if untreated. So using that alternate source of energy, or your ketones, if that continues over a long period of time, your body will go into ketoacidotic shock and result in death. And so it is very important, especially in type 1 diabetics, because of this complete insulin deficiency, that they are treated with insulin. I'm going to talk more about the treatment with insulin with Dr. Bader. So this is just a visual representation of what we just discussed. As you can see on the bottom here, this is time in relation to beta cells. And so as you can see, beta cell mass decreases as the progression of type 1 diabetes continues, and this is a pretty rapid progression. There's potential